given by the wonderful Alyssa Botehlo, who I think needs no introduction to you all, but is a wonderful R2 in our primary care and clin ed pathway track. And so, Alyssa, I'll let you go ahead and get started.
All right. Hi, everybody. Thank you, Gina. Um, I am going to stray from the traditional academic half-day format today, perhaps, and give you a historical talk on rural health equity issues in the U.S. And I hope it will be interesting listening and helpful context for you as residents who are serving the WAMI region in this very culturally and politically divisive time. So, our roadmap for today. First, I'll begin with a quick poll. I'll share my main takeaways for you, and I'll tell you about how I got interested in this topic. Then I'll spend the bulk of my time giving you a history of the US healthcare system with a rural flavor to give you a sense of how rural health inequities are rooted in our political and economic landscape. And at the end, I'll zoom into the Pacific Northwest to give you a brief history of the WAMI network here at UW. But to begin, I want to hear from you. So, what do you think of when you think of rural health or rural America? I'll ask you to do what I've learned is called a chat storm. And by that, like when I count to three, people can just like put their thoughts in the chat. You can reply as many times as you want. They'll just give me a sense of where the headspace is. So 1, 2, 3. Okay, I see home, poor access, low number of providers, small town vibes, a lack of doctors, long distances, Wyoming, challenging, community, food desert, informal care, conflicted, many languages, fam med. Great. There are a lot, IHS, community, resource, profession shortages, full spectrum. That's great. We will touch on many of these topics, making it work. I love it. Um, there are hospitals closing. Yes. Okay. Fantastic. You guys have your finger on the pulse. I hope to touch on some of these themes raised and kind of give you sort of this like broader social perspective on what's going on. So, as the chat shows, you're all familiar with these inequities in disease and healthcare access in the rural US. The CDC reported in 2022 that the rate of mortality from the five leading causes of death rises in correlation with how rural your community is. And you can find data on inequities in rural healthcare access from emergency services to cancer care to abortion care. It's everywhere. Um, my goal isn't to dwell on these numbers, you can find them easily, but to really talk about how and why these inequities came to be. And with that, here are the points I want you to take away today. First, I want you to understand that rural health inequities in the US are not the inevitable outcome of distance. They are due to more than a century of deliberate decisions by our government, our business leaders, and even our medical profession. The second takeaway that I want you to have is to recognize that the rural is not a monolith. I think too often when we talk about rural America, we depict it as this like homogenous white space. We can't forget that racial and ethnic minorities, immigrants, Native people, queer people, they do live in rural areas where often their very existence is an act of political resistance. And I think those legacies of oppression can layer on top of rural geography to create the worst health conditions in the most marginalized rural communities. And yet, despite this pact, history shows us that attention to rural health disparities has always been selective, often focusing on white rural interests, while rural minorities are made invisible or sometimes wrongly pathologized. Um, so I think if like Tuesday's election has made anything clear, it's that we have to continue trying to figure out how white supremacist politics and culture is shaping health across like different rural identities. My third point is that these equity issues are big problems. They're rooted in core tensions at the heart of our democracy. At the heart of our democracy, we're not going to fix them in a day, but we can make meaningful change. And so I'll kind of end the talk with a brief history of UW, the origins of WWAMI, and what they've done to sort of address some of these issues. So a little bit of background. How did I get interested in all of this? Before residency, I did an MD PhD in the history of medicine because I was really compelled by the power of historical stories to shed light on these big power structures that affect our patients' health today. I started grad school in 2016, which coincided with Trump's first election. I can't believe I'm saying that. The height of the US opioid epidemic, and a national crisis in rural hospital closures. And all of these events focused the media's gaze on rural healthcare issues, but I was unsatisfied with the lack of nuance. So I decided to do my PhD research on the history of hospital access issues in the rural US with a social justice lens. And a lot of what I'm going to talk about today draws from that research. As I was working on the dissertation, COVID hit. I was living in Great Falls, Montana, because of my husband's job, and I lived a few blocks from a small regional hospital. All winter, there were like helicopters that were flying over our house, airlifting COVID patients from around the state. And it really hit home for me that the high death toll from COVID in rural areas was due to decades of government and economic neglect, as well as these profound political and cultural conflicts over healthcare should be delivered in the country. So if we don't understand how and why we've gotten to this place, we can't figure out how to move forward. And I think that's where history comes in. Quick note on methods. History research looks really different from clinical research. The gist is that you collect a ton of source material. For me, that included articles from old medical and public health journals, newspapers, magazines, all kinds of documents kept in private and federal archives, like letters, government documents, photographs. I interviewed many rural doctors and other rural people. And then I kind of evaluated all these documents and interviews and identified patterns and themes that I thought told a truer and sort of more compelling story than I saw in some of the existing scholarship in this area. Um, these are some pictures that kind of show what the typical research process looks like. This is on the left, you see a hallway in the National Archives, which is a big federal archive in DC, which has like government records on anything that you could want. You request the records of the things that you're interested in from the librarian. They wheel them to you on this cart, which you kind of see in the bottom right. And then you sit in a room, a small room like you see on the top right, and you like furiously photograph and like sift through like thousands of documents and study them at home. It's super glamorous, I know, but that's kind of how this I have pieced this together. Here are just a couple examples of what my source material looked like. You've got a photograph, a telegram, and then here's just a quick list of archives that are behind some of the stories I'm telling, including the UW archives, which are right here on campus. Okay, with that, let me get to the main story here, which is a brief history of our healthcare system with a rural flavor. Okay, so until the early 1900s, most people lived in rural places. And there wasn't really such a thing as rural medicine. It was just medicine. People gave birth, they weathered illness, and they died at home. And doctors, the bulk of their work was performing house calls. But after World War I, there was a boom in industrialization, and the city really became the center of American economic and political power for the first time. People flocked to work in cities, and when they became sick, they began to turn for medical care in a new urban institution called the hospital. Now, there were hospitals before this, but they weren't really places you wanted to go. They were more like charity homes for people who had no one to take care of them. But in the 1920s, city laborers, they were living in really cramped lodgings in the city. Their family was far away, and getting medical care at home was not realistic. So, to meet this demand for care, American doctors really began to coalesce around the hospital as the heart of the profession. Hospitals offered doctors access to the hot new tech of the early 1900s, antiseptic operating theaters, laboratories, autopsy suites, and X-ray machines. And soon enough, hospitals had really gained such prestige that even the upper classes were willing to pay out of pocket to get care there. And by the 1920s, doctors were competing to get admitting privileges at urban hospitals where they would get the highest salaries and the most resources. And here are just images of two of of the earliest hospitals in the U.S. You've got Bellevue Hospital on the left in New York, and Pennsylvania Hospital there on the right in Philly. So by 1920, the urban hospital was king, and rural doctors began to feel they were missing out on business. Medical journals during this time were peppered with laments about the vanishing country doctor, was a term I often saw. Here's one quote that might hit home for some of you. In 1922, one doctor wrote in the New England Journal that, quote, the physician avoids the rural communities because they do not give him an adequate return on the investment represented by the cost of a modern medical education. Kind of relatable content. I think that a lot of residents share that worry. And so rural doctors really began to demand their own hospitals to fight the rural brain drain to sort of keep doctors in their area. And many rural towns did build hospitals, but in places that were isolated and poor, it was really a Herculean task to raise enough local money to build a hospital and then hire doctors. On top of that, medical care was entirely out of pocket and fee for service. So, in places where most people were too poor to pay for care, there was just no money coming in to keep the hospitals running. And so many rural hospitals failed shortly after opening. On the left here, you'll see a small town's local newspaper ad from the 1920s. It says, open up here quick, asking kind of community members to donate money to build a hospital. And then on the right here, you'll see a hospital postcard, which is a very common way that small towns during this time promoted themselves as good places to live. So for more than 100 years, like more than 100 years ago, we're already seeing that the roots of rural hospital access that are familiar to us today. And the reasons are primarily economic. In like a capitalist free market economy, doctors and hospitals go where the money is, and the money was always in cities. So just as American doctors were flocking to the cities in the 1920s, researchers were discovering that rural disease burden was higher than previously thought. So for most of American history until this point, rural life with fresh air, with open land, was thought to be like healthier than city life, which like people associated with being packed into crowded and unsanitary conditions. But in 1912, the US government formed the National Public Health Service to study and control infectious diseases like typhoid, malaria, and hookworm. And what they found surprised them. As urban water and sanitation systems improved and infectious diseases became better controlled in cities, rural Americans actually began to lag behind their urban neighbors in terms of health. One medical journal noted in 1918, for example, that, quote, the time-honored conception that the health, physical condition, and longevity of the rural inhabitant is better than the city inhabitant is not borne out by recent observations. The 1910s and 1920s were also a time of intense racism and anti-immigrant sentiment in the US. And you might be most familiar with this from learning about the eugenics movement around this time, but racialized thinking was everywhere, including in rural health research. So US public health officers were working in parallel in the domestic rural US and in rural colonized territories in Puerto Rico, Guam, Hawaii, and the Philippines. And they were using the same logics, the same kinds of racist thinking in both of these kinds of spaces. Here is a picture here is a photograph of a US public health post in the colonial Philippines. Both internationally and here at home, public health officers are really focused on explicitly protecting white rural inhabitants from disease, It's kind of this like broader race project to preserve and uplift the white race. When reformers did turn their attention to rural people of color or indigenous communities, they often blamed health disparities on inherent differences in biology rather than extreme poverty. And they often blamed people of color for the spread of disease to white neighbors. So here's an example. The Public Health Service created the nation's first rural county public health department in Yakima, Washington, to fight typhoid in the area's fruit growing communities. These public health officers often blamed and pathologized Hispanic and Asian farm workers, as well as surrounding native reservations as like reservoirs of typhoid, and they focused on protecting the health of white, like tax-paying landowners in these rural towns. So from the very start, I want to stress that that attention to rural health disparities was selective, often focusing on promoting white rural health while either making rural minorities invisible or pathologizing them wrongly. The Great Depression during the 1930s brought like a real reckoning for American lawmakers. Um, there were so many people in poverty during this time, and the government just could no longer ignore the question of how we were going to provide medical care to Americans who couldn't pay. Until this time, medical care was totally out of pocket, and doctors set their own individual prices, like imagine. Um, but as people struggled to pay for medical care, lawmakers really debated whether the US should establish universal health insurance, as many socialist countries had recently done in Europe during this time. And one of the most famous national experiments in establishing an American universal health insurance plan actually took place in rural areas. So during the Depression, policymakers discovered that medical disability was a major reason why farmers defaulted on government loans. So they created federal medical insurance for farmers in order to protect the other loans that they had given farmers. Rural doctors agreed to negotiate prices with the government for these insurance plans because they were just like so desperate to get any kind of paid work. And over the 1930s, more than 500,000 rural farmers were actually enrolled in insurance plans across a third of all rural counties. The Social Security Act did have a national health insurance plan originally, based on this rural experiment and others. But ultimately, universal health insurance was axed because it was perceived as too socialist, too communist during a time of like growing like anti-communist sentiment. And lawmakers also just couldn't really face what quote unquote universal health insurance meant in a racially segregated society. And so instead, a small insurance company called Blue Cross, maybe some of you have heard of it, began to really pave the way for the growth of the private insurance market instead. And ironically, the policymakers who created farm worker health insurance plans fled the country after being accused of being communists, and they went to Canada, where they created Canada's national insurance system. So you're welcome, Canada. Uh, okay. So after World War II, lawmakers tried to pass universal health insurance again, failed due to similar political reasons as in the 1930s. One of the strongest opponents of universal health insurance during this period was actually the American Medical Association, because they saw the government as a threat to doctors' ability to set prices and like control their business. And the editor-in-chief of JAMA actually wrote in 1946 that universal health insurance was, quote, a definite step toward either communism or totalitarianism, and, quote, the first step in the breakdown of American democracy, which I think is a touch dramatic. Interestingly, in the AMA's campaign against national health insurance, they actually used advertising imagery of the white country doctor to really create this romantic vision of the doctor as a self-reliant, enterprising, white male kind of medical cowboy. And they propped this figure up as the opposite of state-run medicine, even though the realities of rural doctoring were like far from rosy. And here you can actually see a few examples of this. There's an advertisement on the left with like a very famous painting of like a rural doctor, like at a patient's bedside, saying like, "Will you keep like we will keep politics out of the picture." And on the right-hand side, we see a Life magazine profile of a rural country doctor in Colorado. So this was just one example of a moment when particular stereotypes of rural doctoring and rural life that are not entirely true are used for these broader political ends. So, what we got instead of universal health insurance was the Hill-Burton Act of 1946, which was a national hospital construction bill. So, we got government money to build more hospitals, but no mechanism to make sure that patients could actually pay for services at these hospitals. And interestingly, rural health actually played a part in getting this law passed. During the World War II draft, the country rediscovered big health disparities in men from rural areas, especially in the South. And so Southern congressmen really latched on to these numbers as a selling point to bring rural hospitals to their states. Just as in the early 1900s, policymakers talked about rural hospital needs in a way where rural coded for rural white interests. For example, Southern researchers and policymakers lumped Black rural health data into aggregate health statistics to kind of really maximize how severe health disparities looked in the rural South and make the best case they could for federal funding. But they never acknowledged that Black communities bore the brunt of these like healthcare access inequities. Um, and of course, Black medical leaders during the time saw right through this. For example, a physician in the leading Black medical journal of this time during the 1940s wrote, and here I'm quoting their own words, the Negro has learned through bitter experience in the past that he is likely to receive only a small proportion of his rightful share in such a project. He all too frequently gets the short end of the stick, and an extremely short end at that. And this physician was right. This is how Hill-Burton bore out. The rural Black Southerners faced the most acute shortages in hospital access. Hill-Burton was designed in a way that ultimately funneled the most resources to white rural communities. Now I want to move to the 1960s, which was a time of huge political change and health activism. Civil Rights Act was passed during this time, and Medicare and Medicaid was finally passed, which led to the desegregation of healthcare and insurance of more people than ever before. This was also a time of many kinds of liberation movements, such as Cesar Chavez and the United Farm Workers. They were really important in championing rural health issues among their political causes. And lawmakers during this time also launched many programs to increase health care to the underserved, like creating federally qualified health centers or FQHCs. They also created migrant health centers, which were dedicated to farm worker health in rural areas. The government also tried to address rural physician shortages through creating the U.S. Public Health Service Corps Scholarship, which was a loan repayment program for those who practiced in rural areas after medical school. And this program still exists. Maybe some of you are a part of it, but it became like a really staple way to address um, having physicians practice in vulnerable areas. The government also created these new immigration policies that granted physicians from other countries expedited entry into the US if they worked in rural or underserved areas. This was, of course, exploitative because we were sending IMGs to places where domestic doctors weren't willing to practice. And these doctors often faced threats to their personal safety as they navigated discrimination in isolated communities. One interesting book about one IMG physician's experiences, My Own Country, which is by the well-known physician writer Abraham Verghese. Okay, so the 1960s and 1970s were also landmark years. One moment. Thanks for bearing with my froggy voice today. The 1960s and 1970s were also landmark years in Native health activism. But let me take you back for a moment. Um, we can't talk about the history of rural health inequities in the US without acknowledging what is called settler colonialism, or the long history of violence and land theft that white Americans committed against Native people. In the 17 and 1800s, our government forced Native people to live on remote and resource-poor reservations where economic development was extremely difficult. And this, in turn, fueled a significant burden of disease. In exchange for ceded lands, Native nations demanded that the US government provide medical assistance. And this led to the creation of the oldest organized rural healthcare system in the US, the Indian Health Service, or IHS. Many of you know that the IHS has a complex history. At its worst, it's been grossly mismanaged, coercive, oppressive of native healing practices, but at its best, it really delivers excellent care despite chronic underfunding. During the 1970s, Native activists organized into a liberation movement called the Red Power Movement to fight for sovereignty, meaning their power to self-govern as independent Native nations. And healthcare was a really important part of their fight. In 1975, Alaska Native villages spearheaded a new law that empowered Native nations to take control over operating IHS services from the federal government. And this was a real turning point in Native health and remains a hot topic in many Native communities today. There's on the right just a very recent New York Times article about this. Okay, so in this final stretch, let me zoom in and talk about the origins of WWAMI. UW was founded in 1945. At the time, it was the only medical school in Washington, Alaska, Montana, and Idaho. And doctor workforce shortages were huge issues in this four-state region. I didn't know this until I did this research, but these four states make up like 22% of the US landmass, which is crazy. In 1969, only 8 out of like 10,000 students admitted to US medical school were from Alaska. And Montana and Idaho each sent less than 30 students to medical school. So in 1970, UW made a commitment to admit 50 students from Alaska, Montana, and Idaho to the School of Medicine with an in-state tuition rate. And the acronym WWAMI was born. UW created satellite schools in the WWAMI states so that these students could do preclinical training in their home states. And they established clerkship sites across the WWAMI region so that students could experience rural practice. There was plenty of anecdotal evidence that students who grew up and trained in rural places were most likely to pursue a rural career. And later studies really proved that this was really proved this concept. So in 1996, Wyoming joined the WWAMI group, and that's how we have the double W in WWAMI today. During the 1980s, the nation experienced a huge wave of rural hospital closures. This was kind of like probably the biggest one before the one we saw in the 2000s. And this was happening in the Pacific Northwest, and WWAMI docs were doing important work in trying to save these institutions. What led to these rural hospital closures? So during the 1970s, healthcare costs had ballooned, in part because Medicare and Medicaid just gave more people access to healthcare. But this was also due to new medical technologies like ICU care, post-surgical care that were just more costly. Um, the Reagan administration responded to this by kind of slashing government involvement in healthcare and letting the free market take reign. And to stay afloat, clinics and hospitals privatized into these big corporations. But rural hospitals, which were these isolated money losers, were rarely brought into deals and they often went bankrupt. So, WAMI doctors, they created a really important consult service to really help rural hospitals in the Pacific Northwest operate better. And their work put UW on the map as leaders in rural healthcare delivery. WAMI docs also spearheaded reform in many other areas of rural healthcare. Here are just a few. They were a leader in telemedicine from the time of the first satellite phone systems in the 1970s, and they created phone consult systems to link UW specialists to rural doctors and also to do medical education across the WAMI region. They also created new programs to train PAs, MPs, dentists, and they pioneered air ambulance systems like Airlift Northwest. As part of my research, I interviewed several UW rural docs, and one of them was a physician named Stephen Kriebel. He practiced for many years in Forks, Washington, on the Olympic Peninsula. He told me that, like in his first 6 months of practice after residency, he delivered more than 60 babies, like, and he sewed up like a logger's sawed off finger like twice a week. Like really incredible career. In talking with me, he really shared that working across political divides was a fact of life. He was a firm believer in universal health care. He said it would have made it much easier for him to maintain his business, but most of his patients didn't agree. Um, and Kriebel and doctors like him, they had privileged identities that made it possible for him to work for 30 years with this kind of like live and let live philosophy. He's white, cis, he's male, he has a lot of social capital in his community. And we just have to acknowledge that this might not be the same reality for practitioners of minority identities. So I think as part of the broader project and understanding how white supremacy operates in these areas, we just have to keep talking about how to keep WAMI training sites safe for trainees that might not fit stereotypical rural like conservative towns, and also continue to foster opportunities to work in minority rural communities. So Kriebel's community, Forks, like is one of these stereotypical, predominantly white, poor rural towns in the Pacific Northwest that went more politically conservative in the 1970s. And why have these sorts of communities voted for conservative candidates whose policies only increase the gap between the rich and the poor, rather than progressive candidates who champion a safety net for struggling Americans? I think this is like a really heartbreaking question, and like one that's been sitting with me, especially after Tuesday. If I had the answer, I would be in politics. Um, and all of these authors have posed a huge range of explanations. But I think the person who had the most incisive understanding of this is still W.E.B. Du Bois, who was a renowned Black sociologist and civil rights activist from the late 1800s. In his writings on Reconstruction, which were the decades after slavery was abolished, Du Bois really described how wealthy white landowners allied themselves with poor rural whites around this idea of shared racial superiority. And they did this in order to prevent class cooperation between poor whites and formerly enslaved Black people who actually shared similar struggles. I think what we see playing out in rural America today kind of might be the newest iteration of this long political strategy where a white capitalist elite has really pitted poor rural white communities against rural communities of color, despite like many shared challenges, and kind of dash the possibility that these groups can come together to fight for healthcare justice. And I think we just have to keep hope that one day this will be a possibility. Okay, so I've given you a whirlwind tour of American healthcare over the last 100 years with a rural flavor. Here are my key messages again. Um, Rural health inequities, not due to distance. There are powerful interests at stake. The rural is not a monolith. We need to question, contextualize, complicate stereotypical sort of narratives of rural life that we see in the media. And changing these inequities is the work of a lifetime, but incremental change is possible. And there's lots of ways you can do it at UW, both here in Seattle and out in the rural. And I'm happy to talk about that if there's as there's interest. Thank you.
Thank you so much, Alyssa. I think we have some time for questions, and it looks like Chris Knight has his hand raised. I love it.
Thanks, Alyssa. That was fabulous. This is relatively more recent history and maybe outside the scope of what you were working on for your thesis, but I'm curious your thoughts as to the rise of the critical access hospital in the late 90s and how that has impacted rural healthcare in general and hospital medicine in particular.
Yeah, the critical access hospital was the major landmark in rural healthcare policy in the 90s. Um, I think it's been like, hugely important to like maintaining hospitals in these areas. The challenge is just how to write legislation in a way that these critical access hospitals don't have the kinds of the kinds of
And
regulatory red tape that make it
so,
hard for them to stay open.
sorry to interrupt, but we should probably define terms for, well, basically everyone else in the room.
Oh, yeah, the critical access hospitals are like hospitals which I think are like under 25 beds, if I'm not mistaken, um, in rural and underserved areas. And the way that they're because of this special designation, that the way that they're sort of paid back by Medicare, Medicaid, their sort of regulations around their finances are a little bit different than other hospitals. They were really important, and I think they're a staple of rural healthcare today. We just have to make sure to create policies that make it like possible to continue reimbursing them the way that they need. And we just have to think about how to push private insurers to extend coverage to people who live in these areas. Um, I think ultimately, like just getting people insured is like the major key.
Thanks.
Okay. There's no other questions. Folks can go ahead and take a break, and we will plan to be back at about 10:40. Leave. Um, and Alyssa, just like tons and tons of graciousness in the chat, including thank yous for sacrificing your voice for this talk.
Yeah, sorry about that, you guys. Thank you so much.